Good morning, everyone. Happy
Good morning.
Tuesday.
And it's a big Tuesday.
It is a big Tuesday. How can I tag you?
Yes. Oh my God. So today's a really big day. Okay, so
Yes.
are we ready? Are we
Yeah,
ready to do it?
let's do
Okay.
it. Let's do it.
On three, okay? 1, 2, 3.
We launched our podcast. And you can see it right there. It's called My Fertility Podcast. It is already live on Apple, Spotify,
Yeah.
and everywhere that you listen to podcasts.
Yes, I've already sent it to everybody. I know.
How long have you heard me talk about I want to do a podcast?
Oh my God. You know what? It's funny. I was thinking about that this morning. You've been talking about it for a long time, and I was like, yeah, sure.
That's right. That's what you said.
Yeah. But I think it was only about a year ago when we actually got a bit more serious about it. And I was like, you know what? Maybe we can do this. Maybe this is an okay idea. So it's been in the works for a while. So it's a very big day for us, and we're very excited.
We've been working on it pretty much since the beginning of the year. We started first Tuesday of January. We started recording and working on it, and we have an amazing producer, Daniela, who is helping us accomplish this. And we've gotten so much feedback through Instagram about our lives, and obviously patients are always telling us at the office, I didn't know this.
Yeah.
You know, I need more information about that. Where can I find the information? So we really want this podcast to be an amazing resource, a source of education and support for anyone in the fertility community, whether you're our patients or not, it doesn't matter. We want you to share it with anybody who might be interested. Leave us a review, follow us, because that is the way that these platforms recognize that the podcast is value and push it forward.
Yeah. And also, you know what, it's not even just for infertility patients per se, because I was talking with some friends over the weekend, and there's so much unknown and so much misinformation about trying to conceive and how you do it and what vitamins and what supplements take and how do you do it and all the logistics, if you will. And so this is I think it's actually a really great general resource for anyone with ovaries who is even contemplating and potentially having a pregnancy at some point. And so we're really excited.
Yeah. So most of the episodes are the two of us teaching you about a topic. We're also going to be having guest interviews, either experts in the field or fertility patients that have been through it and are sharing their stories. So there's lots to come.
Yes.
Right now, there are already 2 episodes out there that you can listen to, and it's also going to be on YouTube. Today, for this Instagram Live, we are going to talk about the part 2 of our endometriosis series, because it is Endometriosis Awareness Month. Last time, we talked about what is endometriosis, how do we diagnose it, and what kind of symptoms are we looking for. And this time, we're going to talk about treatment. And the treatment of endometriosis is tricky because it really depends on what is the goal of the treatment. Is the goal to achieve a pregnancy, or is the goal to manage the pain and the discomfort that you're feeling with endometriosis, or is the goal to suppress endometriosis for another goal, let's say surgery or fertility treatments?
And that's a really good point. I mean, when we are seeing patients in an endometriosis context, 99% of the time it's around fertility. But there's lots of patients who have endometriosis where maybe that isn't the priority right now.
That's right. So let's talk about treatment.
Yeah, so I think the big distinction for us is really, as we said, sort of somebody seeking fertility versus somebody not seeking fertility, right? And so when we're thinking about somebody who is, let's say, coming to see their family doctor or a gynecologist with painful periods, or they've had an ultrasound done that shows that they could potentially be endometriosis, after taking full history, full physical, and sort of examining, could this be endo? The first line treatment for most people is pain medications. So can the pain that you have, the pain that you have associated with your periods, can it be managed with things like Tylenol, Advil, or other NSAIDs, which are non-steroidal anti-inflammatories, right? So again, taking these pain medications as needed. And I think that would be sort of the very first line treatment. From there, if that's kind of not cutting it, or if somebody doesn't want to be taking pain medications on a regular basis, then another big potential option is using the birth control pill. So birth control pill contains estrogen and progesterone, which, it's a little ironic because we always talk about how estrogen grows endometriosis, how estrogen makes endometriosis get worse. But in the birth control pill, it's really about the proportions of estrogen and progesterone. So the way that I sort of think about endometriosis is estrogen will make endometriosis flare, will make it grow, will make it progress. progesterone will kind of tone it down. Progesterone will sort of cut it back. Progesterone will sort of decrease that inflammation, sort of that tone. I always think of it as toning down. And so it's about the proportions of the two in a birth control pill. And so, you know, a birth control pill absolutely can help manage pain associated with painful periods. And I think it's also really important to note that many patients, for sure, from what I hear, is that they can be frustrated, that they don't have a definitive diagnosis, a for sure label, before they get started on endometriosis medications or pain medications or the birth control pill. And, you know, there's a very good reason for that. Because, again, as we sort of talked about, you know, with our previous Instagram Live, the only way to make a definitive diagnosis is surgery. And to actually put a camera into the belly button and have a look. And, you know, frankly, we can help manage those symptoms and deal with the pain before somebody ever needs surgery. Surgery comes with risks. You know, yes, you know, we trained in surgery, we trained as surgeons, but it doesn't mean that we are surgery happy and want to do surgery on everyone. And frankly, it's not realistic either. And so, you know, we can manage these symptoms, manage this pain without necessarily needing surgery. And then, yes, sometimes you may not be left with a definitive for sure diagnosis. It's more sort of a presumptive diagnosis, meaning that we think it's endo and then we're going to treat it as endo. I mean, how do you kind of counsel patients?
Yeah, because I think the important thing is understanding what is the goal of treatment. I mean, everybody wants to understand the why of why they're experiencing something, and I can understand that, of course. But you got to ask yourself, like, is the goal to put a label or is the goal to actually make you feel better?
Yeah.
So if you have a patient who is not looking for fertility treatment, who is not looking to start a family, who is coming to be seen by the gynecologist for the first time with symptoms of pelvic pain, dyspareunia, which is pain with intercourse, there is an ultrasound that is not showing evident endometriosis, we do not see the big cyst or anything like that, I think it's very reasonable to start with, like you say, pain medications with the periods, and if that doesn't cut it, something like the birth control pill, especially if contraception is also desired. And then if the pain is controlled with that and they're getting contraception and they're not getting any of the side effects that are associated with the birth control pill, then problem solved. You might not have the perfect diagnosis, but you've solved the problem of having this, you know, painful intercourse or painful periods and whatnot. And it's important to understand that a lot of people might say, oh, but if I don't know I have endometriosis, then 5 years down the line, when I start trying to get pregnant, it's going to be a problem because nobody diagnosed me 5 years ago. And that also doesn't necessarily apply. Absolutely, so let's say you do have endometriosis because of the symptoms that you're having. You did not get the surgery to have the proper diagnosis. You started on the birth control pill. You're happy because the pain is completely gone and you have a good quality of life. Now you want to establish a pregnancy. You stop the birth control pill and you start trying. And pregnancy can very well happen. And if it doesn't happen, then of course that's when a fertility specialist gets involved, and it could be endometriosis. It could be a lot of other things. It could be the sperm. It could be a quality. It could be a lot of other reasons as well. So it's not necessarily a straight line that if I potentially have endometriosis, you know, you absolutely are going to be having fertility problems, and you absolutely need to take care of the endometriosis now to avoid fertility 5 years down the line. It doesn't work like that. And I think it's really important to understand that.
Yeah, exactly. You know, whether you have a, you know, presumptive diagnosis of endometriosis or a for sure diagnosis of endometriosis when you come see us, really doesn't make much of a difference, to be honest. Because we know that a presumptive diagnosis that, you know, you took the birth control pill, you felt much better, your periods were good, that's very close to diagnosis. I would sort of take that as, you very much likely have endometriosis.
And again, it doesn't mean that if you have that presumptive or real diagnosis, for lack of a better word, it doesn't mean that we're absolutely going to be like, okay, you need IVF right away, you cannot do IUI, you cannot do time intercourse. We're still going to go through the options based on your age, your desires, your AMH level, what the sperm is, what the fallopian tubes are doing, and all of the things.
And this is a great time to plug our next Instagram Live, where we're going to be next week, where we're going to be talking about fertility treatments and endo and how we manage that, priming, not priming, meds, suppression, FET protocols, all that good stuff.
All of that stuff, right? So we've talked about pain medication for endometriosis. We talked about the birth control pill. What would be the next oral medication?
So then there are other medications out there that can help with endometriosis pain. And again, they're all working by suppressing the endometriosis, right? Sort of toning down that endometriosis. And so one very popular medication, there's one called Vizan. So Vizan is a progesterone medication. So again, remember we talked about progesterone being really good at sort of dampening and toning down the endometriosis. And so that's a pill that somebody can take, and you don't have those estrogen side effects, and you don't have those same risks that are associated with a birth control pill. And that can be, very important for some people. And so Vizan, a daily pill that can work very well to help suppress the endometriosis as well. And then the newer medication, there's a newer one on the market called Orilissa, which again is another pill, and it is a GnRH antagonist, which is something we use a lot in the world of IVF. But without going, too much into detail, it basically works again by suppressing the brain's ability to send out hormones that make the estrogen and progesterone. So again, in another way, sort of keeping that estrogen down to help prevent the endometriosis from growing further, from continuing, and again, toning it down. And then, of course, the one that is classically used for so long was always Lurpon. So Lurpon, this one is an injection medication. And it's an injection medication that's given either every month or every 3 months, depending on the dose. And it also will suppress those estrogen levels to, again, tone down the endometriosis. Lurpon has been around for a very, very long time. And for a long time, before the Orilissa, which again is very new on the market, was used probably most commonly for endometriosis. It was used a lot. The problem is Lurpon comes with really crummy side effects. So it puts people essentially into a medical menopause. So,
which is temporary, right?
Yeah, which is temporary. As soon as you stop the Lurpon, it washes out of your system. Those side effects will stop. But while people are taking it, you can get the hot flashes, night sweats, dryness, all those kind of classic menopausal symptoms, and they can come quite suddenly and quite fast because you're going from high estrogen levels to sort of them slamming down. And that the side effects can be quite challenging.
Yeah, and another issue with Lurpon is you couldn't be on it for a long time.
Yes.
And with these new medications like Vizan and Orilissa, you can be on the birth control pill. You can be on it for a long time. So that's another big difference as well.
Yeah, for sure.
So we talked about medical treatment of endometriosis in women who are not looking to conceive. Next Instagram Live, we're going to talk about medical treatment of endometriosis in women who are going through fertility treatment. The last thing we didn't talk about is surgery. Surgery has a treatment for endometriosis in women who are not trying to conceive. So surgery, of course, like we mentioned in the last Instagram Live, it is the gold standard for diagnosis. Most endometriosis surgeries are done through laparoscopy. That means little incisions in the belly button and on the sides of the bellies. Camera goes in. Sometimes you can use a laser to remove the endometriosis. Sometimes you can use other laparoscopic instruments to do that. And the idea is to see where the endometriosis is and either like cauterize it, or an ablation is also called ablation, or actually do like resection of the tissue that has endometriosis as well. So surgery is great. It can really help with pain. So of course the diagnosis, yes, but it can also really help with pain. And the main concern with surgery is that it's basically very difficult sometimes to see an endometriosis surgeon. The waiting lists are very long. Surgeries also come with risk. So there is a risk of infection, bleeding, perforation, damage to the bowel. So it's a recovery period. Even in the context of surgery, many times medical treatment is necessary prior to surgery to make the endometriosis less of a flare at the time of surgery, or even after surgery is completed. Many times you need to be on medication as well to continue to not prevent the recurrence of endometriosis after surgery.
And that's a really good point, I think, because as long as you, while you continue to have periods, while you continue to cycle and ovulate, the endometriosis will continue to grow. So it's not like you can have surgery and then that's it.
That's right.
Right? So you may have surgery and then you might be okay for some period of time, and then the endometriosis can absolutely grow back. And then you might be faced with needing to still go on medications or potentially have a secondary surgery, right? And so that's why it's not a definitive answer.
Now, most endometriosis surgeons would be very cautious of doing surgery in women who are planning fertility either in the immediate future or even in the distant future. And that is because in some cases, especially when the endometriosis is affecting the ovaries And we know that the ovaries have big cysts on the endometrioma, or the ovaries may not have endometriomas, but if they're stuck against the abdominal wall and you have to peel them off the pelvic side wall, we know that is going to impact the ovarian reserve. And of course, having a lower ovarian reserve can potentially, the keyword is potentially, in fact, impact your ability to conceive. Low ovarian reserve is not associated with a live birth rate, but it is associated with the number of eggs you get during an IVF cycle. So if you have somebody who's done surgery for endometriosis, their ovarian reserve is now very low. They tried to conceive, they were not able to conceive, and they need to do IVF, and we're only getting 1 or 2 eggs, then that becomes a problem. So a lot of times endometriosis surgeons, rightly so, would be cautious about doing endometriosis surgery in women who are planning to conceive in the near future or even in the more distant future. So that would be, they many times they refer them to us just for an assessment, a conversation about that. And many times they do advise egg freezing or doing an IVF and freezing embryos prior to surgery. Not every time, but certainly worth a discussion.
Absolutely, yeah. And I think that this is an area that is, it's great. That's a bit muddy, and I think it's not well understood. And I think in the sense that, and I tell people, even in the hands of like the best endometriosis surgeon in the world, right? This is not to say that endosurgeons are great. They're amazing, and I'm always in awe of the crazy things that they can do. But, even in the hands of the very best surgeon, endometriosis is inflammation, it's scarring, things are stuck. And so having to take off that cyst of endometriosis from an ovary, inherently you're going to end up damaging some of those baby eggs, some of those follicles. And so I've definitely had lots of patients where, they've done surgery, or they're seeing me after surgery, and their egg reserves have really taken quite a dive, unfortunately. And, oftentimes surgeons will talk about, oh, well, it can recover in a few months. Yes, it does partially recover, let's say in the first few months after surgery, but that doesn't mean it's going to recover completely. That's right? So usually, it can be suppressed for a few months after, but I personally can't say I've ever seen it recover completely.
No. Yeah. And again, it's important to know this really applies when the ovaries are involved. There are times when endometriosis surgeon will counsel patients to say, listen, the ovaries are not involved. I'm not worried that I'm going to be touching them. I'm going to be working in other areas of the pelvic, of the pelvis. And then that's perfectly fine. Yeah. So that would really carry a much lower risk than when there are endometriomas in the ovaries or when the ovaries are full of scar tissue.
Yeah, absolutely.
Okay, so we are going to be answering some questions from here. Thank you very much for everybody that submitted questions, by the way. We have lots of them. The first question is more information about bowel endometriosis, please. So bowel endometriosis basically means that endometriosis has impacted the bowel. That can be noted with really painful bowel movements. That can be noted with, the time of the period. Patient might have diarrhea, might have a lot more bloating that would be considered normal. Some patients have vomiting at the time of their periods as well due to bowel endometriosis. Again, it's very difficult to actually diagnose it with an ultrasound, although the new technology of mapping ultrasounds is getting much better for that. But generally the standard would be laparoscopy and actually seeing the impact of the bowel on the bowel. There are many times when general surgeons are called into an endometriosis surgery to do a bowel resection because endometriosis have impacted the bowel, or to look at it and see, what is the impact.
Yeah, for sure. So it's something that it definitely takes a team approach of bowel endometriosis.
And generally it can be treated the same as endometriosis anywhere else, which is the suppression with the medications that we talked about, or with surgery, with or without a bowel resection.
Yeah. So another question that we got, okay, so what is silent endo? Is it possible to have endo without the awful pain? So silent endometriosis or occult endometriosis, it's sometimes called, is this idea that you can have this endometriosis, meaning that you have, the lining of the uterus is outside of the uterus, it's in the pelvis, could be hanging out on top of the bladder, bowel, pelvic side walls, appendix, etc. But you're not having the characteristic kind of debilitating, painful periods. It is absolutely possible and absolutely happens. The challenge is that it's really hard to say how many women have it, right? Because if a woman's not having symptoms and we can only make a diagnosis through surgery, we can't go and take, 100 women and do surgery on them just to see if they have endometriosis. And so that's what makes it really challenging to figure out how common is this, how many women have this. I think in our last Instagram live, we shared some stories about our own experiences with patients who had silent endometriosis. That was like a big surprise at the time of a surgery for something completely different. And so that's silent endometriosis or occult endometriosis. And then, so it's absolutely possible. The challenge is, I guess the question that we often get is like, well, how do you know I don't have silent endo? And that's to be honest, we don't. Because, if we can't see it on ultrasound and you're not having the symptoms, the only way to know for sure would be to go to surgery. But that means that we would have to take all of our fertility patients probably to surgery just to look for it, which is not practical and comes with risks. And so, that's the real challenge with silent endometriosis. What I will say though, and this is a bit of a preview in terms of our next week's discussion, just because somebody may have endometriosis or potentially has silent endo, doesn't necessarily mean that there is some special protocol or special something that's going to make massive differences. And so it's a bit of a preview of next week.
Fertility outcomes.
Yeah.
The next question is, do you recommend genetic testing of embryos for endometriosis patients? And yes, we do. Absolutely, we do recommend it. For all the reasons that we would recommend genetic testing outside of patients that don't have endometriosis, mostly improve implantation rate and decrease miscarriage rate.
And especially helpful if somebody is doing IVF and then they're planning for an endometriosis surgery, right? If they're genetically tested embryos, we can be a lot more confident that they're going to succeed later on, and makes it a lot easier for us to sort of give you reassurance that yes, you've got your embryos for your kids, let's say before you're going to surgery.
And this is a great question that we have already sort of answered. The question is, does not having laparoscopy surgery for endometriosis affects implantation of a PGS tester embryo?
Yeah.
And the answer is no.
Yep.
No. There was actually a very good study looking at implantation rates of genetically tested embryos that were normal in endometriosis patients, with or without surgery, with or without treatment. Actually, I'm getting into the next slide. But
Yeah.
in doing natural cycles, and they didn't see a difference in implantation rate. So no, you do not need to absolutely have a laparoscopic surgery prior to implantation of a genetically tested embryo.
Yeah.
And the next question is
okay. So recommend surgery to remove a less than 3 centimeter endometrioma before or after egg retrieval. Okay. So this is a question if somebody has a 3 centimeter endometrioma, so that's cystic endometriosis, should they have surgery? I guess it's two-part. Like, should they have surgery, number one, and number two, should it be done before or after egg retrieval? So number one, so if somebody has an endometrioma that's 3 centimeters, should they have surgery? Well, the question is really, do you have symptoms? Is it bothering you? Do you know? Is this something that you only found out because you ended up having a bunch of ultrasounds in a fertility clinic? Or is it something that you've known about that's causing you issues, that's causing you symptoms? If it's causing you symptoms, then there may be value in talking about surgery and discussing surgery. Then there's like the order and the timing of things. So ideally for us, we would do egg retrieval first, make embryos, be confident that we have good embryos, then potentially surgery, and then do an embryo transfer. That's sort of applicable to, 90% of cases, not 100%. Some people may also say, I've also heard it said, maybe it's good to remove the endometriosis before an egg retrieval if you can't access the eggs.
That's right.
But again, in this case, when it's 3 centimeters, that is relatively small in our world. And so typically my general advice is make embryos, do your egg retrieval, surgery, and then embryo transfer.
That's right. The next question is it true that most patients with decreased ovarian reserve have endometriosis? I don't think that's true. Would you say that? No.
I mean, I think the number one cause of decreased ovarian reserve is age.
And genetics as well, not necessarily endometriosis. Now, of course, people can have two problems, so there's no question about it. Yep. But I don't know that endometriosis have been directly linked to decreased ovarian reserve, and I don't know that anybody that has decreased ovarian reserve, we should be thinking, it's silent endometriosis.
Yep, absolutely.
Mm-hmm. Is endometriosis a likely cause of unexplained infertility? I wouldn't say it's a likely cause.
No.
I mean, again, we don't know what causes unexplained infertility. That's why it's called unexplained infertility. it is possible that somebody is diagnosed with unexplained infertility. They do 3 IUIs and they're not pregnant, and they do IVF, and there is some embryos are being made, and then at some point the patient might say, I'm be having a lot of pain lately, and you end up having endometriosis surgery. Maybe they had an ectopic and they had to go for surgery, and then you see the endometriosis there. So that certainly happens frequently. Does that mean that was the cause of unexplained infertility all along? That's hard to say.
Yeah, I mean, I would really say, it's not a likely cause, because and I tell patients often, the fertility testing that we have available is so limited in terms of what we're actually able to see and to figure out in sort of like our standard fertility testing panel. There's so many questions that we can't answer, and so many issues and things that have to go properly for an embryo to implant and stay implanted. I think endometriosis is just sort of one potential cause out of a list of 1,000 for unexplained infertility.
There weren't any other more questions, but some people had commented about how great the initiative of the podcast is.
Please go listen. Please give us a rating too. Pretty please.
We'll be back here next Tuesday to talk about the treatment of endometriosis in the context of fertility. So again, IVF protocols, FET protocols, IUIs, and things like that.
Yeah.
If we have time, I'm going to share my own journey with endometriosis. And if we don't have time, I'll share it another time. Don't worry, you're still going to hear it. You're not getting away from it.
And so we released 2 episodes today.
Yes.
We've got another episode coming next Tuesday, and then 1 episode every Tuesday until the end of time.
That's right. Until forever.
Yes.
All right, guys, take care. And thank you so much for all of your comments, your support, your shares. It means so much to us. Thank you, thank you, thank you.
Absolutely.